You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for June 27th, 2025. This week, FDA approves triple drug polypill. My opinion has changed on the polypill. A deep dive into invasive PE therapies, heart disease trends, and diabetes care is on fire. First, an announcement. Next Friday is our Independence Day holiday. It's one of my favorite holidays. This Week in Cardiology will therefore return on July 11th. Also, next weekend is the start of the Tour de France, and even if you don't love professional cycling, this year could be one of the best ever races as three of the best cyclists in the world come to the race fit and healthy, and I can't wait to watch. The second announcement is a sad one. I learned this week that fellow medical conservative Dr. Andrew Flappen of Edinburgh died suddenly. Andrew has invited me to speak twice at the Royal College meeting. I have enjoyed my time with him immensely. He was a force of nature and a doctor's doctor. To my colleagues in Edinburgh, I offer my condolences. Okay, first topic is FDA news in hypertension. The FDA this week approved the 3-component polypill for hypertension. Its brand name is going to be called Plic, which is a really silly name. I can't even hardly pronounce it. The polypill includes an ARB telmisartan, the calcium channel blocker amlodipine, and the diuretic indipamide. There will be a standard dose pill with standard doses of the 3 drugs, but there's also going to be 2 polypills with lower doses. Now, my feelings have changed about the polypill. I used to be dead set against it. I thought it was dumb and it would be far better to just titrate doses of selected drugs. But now I am more open to the whole simplicity thing. As I age, I grow more and more interested in minimally disruptive care, a concept began by Mayo Clinic Dr. Victor Montori. The idea is that life is for living, not being a patient. Getting prescriptions filled is a huge pain in the butt these days. I've learned this firsthand. So the idea of taking one pill that has a better chance of controlling blood pressure is absolutely minimally disruptive compared to titrating 2 or 3 pills which each require a separate prescription. And the evidence for polypill efficacy is quite decent. Lancet published an RCT comparing the triple polypill to 3 different 2-drug combinations, and it fared well. The triple drug polypill lowered the systolic blood pressure statistically more than the other combinations. Now, this was a small efficacy trial, but there were no significant differences in hypotension, though more patients in the triple therapy arm had out-of-range sodium or potassium values, but, quote, very few clinically significant electrolyte abnormalities occurred in any of the groups. Also in 2024, Jack published an RCT of about 300 patients who had mild to moderate hypertension, and this trial randomized in a 2:2:1 ratio the polypill quarter dose, which was telmisartan 10, amlodipine 1.25, and an indipamide 0.625, a polypill half dose, which was telmisartan 20, amlodipine 2.5, and indipamide 1.25, or placebo. And it found that blood pressure reductions, the delta versus placebo, was about 7 to 8 millimeters per mercury. At week 4, clinic blood pressure control, that was defined by less than 140/90, was 37% for placebo, 65% for quarter dose, and 70% for half dose. Both doses had highly significant p-values, and the adverse effects were similar. And then finally, in 2023, JAMA Cardiology published a meta-analysis of 7 trials with 1,900 patients looking at 3 and 4-component polypills versus monotherapy or placebo. Again, the polypills were more effective blood pressure-lowering drugs, and there was little or very little differences in adverse effects. Now, I want to say a word of caution. These trials enrolled 59-year-old patients. They had run-in periods, and in trials, Patients are motivated, clinicians are motivated, and there are research nurses. In other words, the trial environment is seriously protective. The practice of evidence-based medicine, though, requires us, the practitioners, to be mindful of the external validity of trials. So giving these drugs in a single pill is not for frail, elderly patients with serious comorbidity. Patients on these drugs should be given follow-up. But again, I stress the sole point of preventive therapies, like treating hypertension in middle age people, is so that they become old age. When patients successfully make it to old age, there's a reason for caution. Benefits of preventive therapies become less and side effects become more frequently when they're used in older patients. The thing about the polypill is that it offers a single best chance of getting control of blood pressure. Simple is better, not only because it is less work for the patient, but in my experience, if you get early success, it's more likely to lead to adherence and in confidence in the clinician. I don't know how much this polypill will cost. The 3 components are not at all costly, but putting them together could be, and that would be sad. I am upbeat about polypills. I changed my mind. All right, next topic is a deep dive into invasive PE therapy, pulmonary embolism therapy. We need to talk about a new kid on the block, and that is this business of interventional PE care. In my hospital, our 2 EP labs are bookend the 3 cath labs. And I like to visit the cath labs as both a curious person and a journalist. I often see my colleagues treating PE, and the pictures are impressive when a doctor literally sucks a clot out of the pulmonary artery. My former partner for decades, 2 decades, Tom too, he became the chief medical officer of Inari. I loved working with Tom. Our cubicles in clinic were right close by. And by the way, in private practice, you only get a cubby. My diplomas are not on the wall, they're in boxes. So Tom pushed me on the evidence, and I once debated him in front of the entire medical staff about PCI for stable coronary disease. I had all the data and was sure I was going to win the debate. And Tom told scary stories, and I was crushed. Anyways, I liken endovascular clot aspiration in PE to clot aspiration in MI and cerebral protection devices in TAVR. Seeing clot that was once in the body has huge persuasive properties, but scary pictures of clot are not evidence. So the European journal Open has published an eye-opening review on the endovascular treatment of intermediate risk PE. While I know what you are thinking, review articles are terrible to read, and I would agree in most cases, but this review, however, by Armin Shahryar is superb. There's sharp, short sentences, there's lots of subdivisions. I'm going to link to this review article, and there are 2 reasons to read it. One is if you're interested in PE care, which is increasingly common in cardiology practice, and the other reason to read it is that it's a shining example of the failure of evidence-based practice to determine best therapies. So advocates of EBM should read it for its many lessons. Okay, here's a brief review. Now, PE is obviously a leading cause of cardiovascular mortality and morbidity. But the hard part of PE treatment is that PE is not one thing. It's kind of like AFib in that way. PE can be mild, even incidentally discovered on a CT done for other reasons. And it can be severe and devastating, causing shock and collapse. The extremes make for easy decisions. But most people with PE present with, quote, intermediate levels of risk. Endovascular procedures have increasingly been used in the past decade. And it's interesting that the increased use parallels almost exactly the rise of PERT teams. What's PERT? PE response teams. Now, since so few patients present with extremely high risk or extremely low risk, most endovascular therapies are deployed in intermediate risk patients. The problem is that there is little evidence for use of these procedures in intermediate risk. In fact, no guideline gives interventional therapy a Class 1 recommendation in this case because there is not Class 1 level data. Okay, let's start with the beginning. A word on risk stratification and basic management. Everyone agrees that the first step in PE care is to risk stratify using clinical, lab, and imaging parameters. The ESC defines high-risk PE by hemodynamic instability, which is associated with a 30-day mortality exceeding 15%. These patients require immediate adjunctive intervention directed at reperfusion, either medical, endovascular, or surgical, to prevent death. By contrast, low-risk PE, characterized by a normal blood pressure, low clinical severity, and no evidence of cardiac dysfunction, these patients carry a low mortality risk of less than 1% and can generally be safely managed with anticoagulation alone, even in the outpatient setting. Intermediate risk patients encompass 25 to 60% of all hospitalized PE cases. These patients have stable vital signs but other concerning features, such as cardiac dysfunction. Short-term mortality rates in intermediate risk PE range from 1 to 3% in clinical trials and 3 to 5% in observational studies. And, according to the ESC, patients with both imaging and laboratory evidence of cardiac dysfunction should be deemed intermediate to high risk. And this is where the controversy and uncertainty come in because of the limited data. Okay, what's the rationale for endovascular therapy of PE? Where did it come from? Well, it stems from a seminal trial called PEITHO, P-E-I-T-H-O. This was in 2014 in the New England Journal of Medicine. The RCT was of systemic lytics plus heparin versus heparin alone in 1,000 patients with intermediate risk PE. And that study found a small benefit in its primary efficacy endpoint, which was 7-day mortality and hemodynamic decompensations. It was like 2.6 versus 5.6, so that sounds good, right? A p-value of 0.02. However, this was outweighed by the risk of major extracranial intracranial bleeding. Extracranial bleeding was 6.3% versus 1.2%. And intracranial bleeding was huge, 2.4 versus 0.2%, and both those were highly significant. Thus, the rationale for endovascular therapies was born because systemic lytics worked, but were far too dangerous. All right, now the next topic of the paper is how lax FDA regulation led to this dubious evidence. So 5 endovascular devices hold indications for PE therapy in the U.S. In 2014, the ECOS ultrasound-assisted thrombolysis catheter from Boston Scientific became the first FDA-authorized endovascular therapy in acute PE. This catheter was initially studied in a small RCT and a prospective cohort study, and both of these studies demonstrated short-term improvements in the RV to LV ratio. Thereafter, get this, 4 analogous devices have passed muster in the FDA 510K pathway, where a device only has to be shown similar to a previous device. Now, these include clot extraction devices of one sort or another. Now, the authors of the review paper in European Heart Journal Open then discuss 4 important and yet unanswered clinical questions. This is a nice way to do a review, by the way. So one question is surrogate validity. Measures of RV dysfunction, such as RV size greater than LV size, have been adopted in earlier studies because these were associated with early mortality. But experts now, including the AHA guideline writers, acknowledge uncertainty as to whether rapid improvements in RV dysfunction is a reliable surrogate for outcomes. I would add that RV size is like your LDL. No one cares about their echo image. They care about being alive and breathing well. All right, another remaining question number 2, asks whether interventional therapy plus anticoagulation beats simple anticoagulation alone in the short and long term. Only 3 small trials have addressed this question, and the results are mixed. Less than 200 patients have been studied in RCTs with these devices, and I know it's crazy. And again, I remind you that the FDA allowed these devices based on similarity to others, not evidence of benefit. Remaining question number 3 is whether endovascular therapy added to anticoagulation improves clinical outcomes for patients that include mortality, hemodynamics, symptom resolution, and sequelae that contribute to long-term mortality, such as the chronic thromboembolic pulmonary hypertension or post-PE impairment syndrome or recurrence of disease. For instance, in intermediate high-risk PE, short-term mortality might range from 1 to 3%, but chronic pulmonary hypertension develops in 2 to 3% and post-PE impairment in 10 to 30% of patients. And despite the rise in endovascular therapy, there still have been no RCTs. Now, the good news is that there are at least 3 ongoing trials. My hospital is participating in one of them, and I'll tell you that the problem is extremely strict entry criteria, and that's going to limit external validity. The 4th remaining question, of course, is safety of endovascular therapy. While all the devices limit systemic thrombolysis, which is a good thing, some of these catheters involve large bore catheters in the heart. And the authors cite a large, real-world, non-industry supported observational study published in the Journal of Society of Cardiovascular Angiography that found much higher rates of major bleeding with endovascular therapy than previously described. These were up to 10 to 15%, and I'll cite that study. All right, the European Heart Journal Review article, authors devote another section to explaining the popularity of these devices in the absence of evidence, and I found this a really interesting read. Let me review some of it. One cause of the popularity of these interventional devices are the PERT teams, who are led by interventional-minded doctors. Another, and perhaps stronger tailwind for the excitement behind these devices is reimbursement changes. Now, I did not know this, but following an FDA 510(k) market approval, insurers independently determine if they will cover a device. Now, CMS is the largest insurer, and its decisions influence private insurers. But in 2021, CMS controversially ended its non-coverage policy for PE devices, which then allowed local Medicare contractors to decide. This decision by CMS accelerated coverage and in turn accelerated use of these devices. CMS, the authors wrote, could have required ongoing evidence generation within its CED mechanism, that is, its coverage with evidence development, but alas, they did not. And by the way, a sidebar here is I feel like the concept of coverage with evidence for everything new could be the most important policy ever employed. Now, the 3rd reason for rising popularity of these treatments is marketing of observational research. Now, we know this is a common thing. Industry sponsors registries. The registries are voluntary, so only the best patients get in them, and so the registries studies produce favorable results. And then these favorable results get made into ads. Companies then spend money paying doctors to speak and travel. Here is a direct quote from the paper. Quote, "Until its recent acquisition by Stryker, Inari Medical was a relatively young company that derived 2/3 of its revenue from the FlowTriever sales. Since its initial public offering in 2020, the company had rapidly increased its volume and magnitude of general physician payments. In 2020, it made 3,500 general payments to physicians, amounting to nearly $1 million. Over the next 3 calendar years, 21, 22, and 23, these figures increased to 2.5, 4.9, and 6.7 million respectively, representing 0.9, 1.2, and 1.4% of its top-line revenues." Now, it's not just physicians who are making out here. Hospitals, too, benefited financially via higher DRG reimbursement rates. This is hilarious. Get this. Hospitals get paid on severity of disease. Using a device increases severity, so it's self-fulfilling. Here's another quote from the authors. Quote, "Between 2021 and 22, the reimbursement for endovascular therapy for PE with major comorbidity or complications nearly tripled from $9,000 to $25,000. Accordingly, an interventional PE service line can generate high revenues for a hospital system," end quote. Boom, there you go. PRT teams, PERT teams make money. Now, I don't mean to beat up the PE treatment people. I highlight this topic because of its EBM lessons. In the heyday of cardiology, we were leaders in a generation of evidence. We generated tons of evidence, post-MI care, heart failure care, in arrhythmias, we had CAST and AFFIRM. So it's weird that the same evidence-generated ethos did not infect the PE world. Now, which of these devices, if any, is better is a knowable question, but it won't come from observational studies. It has to be via RCTs, and I realize that PE patients come in different varieties, but nonetheless, these studies could have been done, and then we would know. And you might say, John, well, there's ongoing trials now. Calm down. And my counter to that is it's largely too late. Equipoise has been injured. When you return from a clot extracting course on a beach resort, do you think you're going to be energized to randomize a PE patient in a trial or do the clot extraction? When reimbursement is favorable, do you think doctors will be keen to randomize or do the procedure? I have already sent multiple notes to my friend Vinay Prasad encouraging him and Marty Makary at the FDA to do something to tighten device regulation. I'm not against approving early generation devices, but there has to be stronger post-marketing requirements for evidence with trials, and there currently is not. But in truth, as professionals and scientists, we should not need the FDA to help us. We should want evidence. We should require evidence before exposing our patients to unproven therapy. Sadly, though, the recent experiences with left atrial appendage occlusion and PE, and now, of course, tricuspid valve interventions, don't shine a favorable light on the scientific aspects of our profession. All right, next topic, heart disease trends. The Journal of the American Heart Association published a very interesting paper on trends in heart disease mortality. It really makes you think. A Stanford-led team used the National Vital Statistics at the CDC to present data on heart disease mortality over the past 50 years, from 1970 to 2022. Here was some key findings, and some of it was good news. Heart disease deaths are decreasing. In 1970, heart disease accounted for 41% of deaths. That has declined to 24% of all deaths. And life expectancy went from 71 years, 1970, to 77.5 in 2022. Now, the proportions of types of heart disease deaths have changed dramatically. Over the past 50 years, age-adjusted heart disease mortality decreased by 66% from 1970 to 2022. In 1970, more than 90% of heart disease deaths were ischemic. Ischemic causes of CV deaths declined to 53% in 2022. Now, one of the reasons may be this statistic. Since 1970, age-adjusted mortality from AMI decreased by 89%, from 354 in 100,000 to 40 in 100,000. Since 1970, age-adjusted mortality from any ischemic disease decreased by 81%. But conversely, since 1970, age-adjusted mortality from other heart disease subtypes has increased by 81%, with the greatest increases in heart failure, 146% increase, hypertensive heart disease, 106% increase, and arrhythmia, 450% increase. For instance, in 1970, those other subtypes, heart failure, hypertensive, and arrhythmia, accounted for just 9% of heart disease deaths. Now, these other subtypes account for nearly half, 47%, of heart disease deaths. So what are my comments? First is that the authors rightly acknowledge limitations in the use of coding. For instance, disease names have shifted somewhat, and arrhythmia-related deaths may in fact be related to underlying ischemic heart disease. So ischemic heart disease could be undercounted. But limitations aside, it's worth thinking about the data. The fall in deaths from AMI and ischemic heart disease represents a shining example of excellence in both cardiology and, I'd say, public health. The reduction in smoking stands out as a huge success in public policy, and surely this has enhanced the lives of millions of people. I would also laud my interventional colleagues. I spend a great deal of time on this podcast criticizing the overuse of intervention in stable CAD, but the acute treatment of MI has been one of the most important medical achievements of a generation in all of medicine, not just cardiology. Young people who listen to this podcast cannot appreciate where we were when I began medical school in 1985. MIs then were largely treated with morphine and Swan-Ganz catheters. Now, people come in with an anterior MI and they leave with a Band-Aid on their wrist and a normal ejection fraction. So impressive has been the trends in AMI care, it's hard to even find an ischemic cardiomyopathy patient who qualifies for primary prevention ICD. Keep in mind, too, that this marked reduction in MI deaths bears on screening for heart disease. Namely, the better we get at treating a condition, the less value there is in finding it early. We don't screen for appendicitis or gallbladder disease or pneumonia because we can simply treat those problems when they occur. Now, acute MI isn't quite there, but it's approaching that. By the way, if you're young and looking for a job that has meaning, I can't think of a better job than interventional cardiology. Nearly every day, you are saving or enhancing a life. The problem, of course, with interventional cardiology is that it is hard because, like delivering babies, MIs happen at all hours. Another factor in the reduction of death from ischemic heart disease could be statins, right? Statin use has gone from about none in 1970 to 45% of adults over the time frame. Since we know that statins consistently reduce CV events by about 25%, not having an MI in the first place is a good way not to die of ischemic heart disease. I, for one, think statins play a consequential role in lower ischemic heart disease deaths, but smoking and MI care are much larger causal factors. Now, my final comment is the alarming language both in the paper and online regarding the rise in other forms of heart disease. And yes, the rise in obesity, which has led to more hypertension and more AFib and more HFpEF, is a big concern. I don't want to downplay it. Obesity is a public health crisis and largely a public health failure. But on the other hand, it's important for doctors to understand that all people die. If you reduce MI deaths and increase life expectancy, what do you think happens? People get older and they die of other diseases, such as heart failure, atrial fibrillation, dementia, cancer, and falls. This is normal. It's still a good thing to extend life and enhance life, but it's also important to recognize that reducing ischemic heart disease deaths does not magically reduce healthcare costs, because eventually aging people develop some sort of disease, and if it is treated, money is spent. That's fine. The reason to improve treatment of heart disease is not to save money, it is to extend quality of life. If our therapies do that, then it is worth the money spent. All right, next topic and final topic. It's just short. It's diabetes. I'm not going to go into the specifics, but at the recent ADA meeting in Chicago, there was a trove of studies and news that come out that should be on our radar. For instance, a study showed early data on once-weekly insulin. Think about that. If you have type 1 diabetes, once-weekly insulin. There were early studies on other GLP drugs as well as combination of drugs, and I think, my friends, that semaglutide and tirzepatide may become the simvastatins of GLPs soon. There was even some encouraging data on recombinant gene therapy for type 1 diabetes. The diabetes world is advancing fast, and I think it's only a matter of time before cardiologists are prescribing GLP-1 drugs like we did for SGLT2 drugs. And finally, before I close, I'll say that there's been another BMJ investigation on more potential, emphasis potential troubles in the ticagrelor evidence base, and I'm going to look into this over the holiday, and I'll have a report on the next TWIC podcast. I will see you again in week 2 of the tour. And that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, take the time, give us a rating, or write us a review. This helps others find us. And of course, if you don't agree with something I said or have something to add, send me an email or write a comment on the website. I always learn from listener feedback. Until 2 weeks, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.